Thank you for the introduction. Good afternoon to all. Today I will briefly talk to you about the modulation of immunogenic cell death using Calreticulin-nanoparticles in combination with focused ultrasound to treat melanoma tumors. The success of several chemotherapeutic agents, focused ultrasound, radiation therapy, and other modalities have been attributed to some extent to their ability to induce an immunogenic cell death or ICD in tumors. ICD is a phenomenon in which dying cancer cells expose resident proteins like calreticulin on their surface, along with the release of soluble mediators like heat shock proteins and HMGB1, which can activate dendritic cells and cytotoxic T lymphocytes that in turn can destroy the cancerous tissue. It would be interesting to talk about ICD in the context of immunogenicity of tumors. B16-F10 melanoma tumors are poorly immunogenic and are characterized by low immune cell infiltrates, along with rapid proliferation rates in contrast to the highly immunogenic tumors like CT26 colon cancers. One reason for tumors to be poorly immunogenic could be due to the imbalance between immunostimulatory and immunosuppressive proteins in tumors. For example, about 40% melanoma patients have been observed to have low calreticulin exposure on their tumor cell surface compared to the others. Additionally, there can be higher levels of immunosuppressive checkpoints like CD47, PD-L1, and PD-1, which can inhibit the activity of immune cells against tumors. There is a need for safe therapeutic approaches that harness ICD to create a balance between these two sites. We developed novel liposomal nanoparticles that can deliver a key ICD mediator, calreticulin, in the form of gene to use in combination with focused ultrasound thermal stress of about 42 to 45 degrees Celsius to treat local and distant melanoma tumors. We evaluated the therapeutic efficacy of calreticulin nanoparticles or CRTNPs with focused ultrasound, which I will call as CFUS in the following slides, in a murine model of B16-F10 melanoma. 3 intratumoral injections of CRTNPs were performed 2 days apart, and focused ultrasound heating was performed 24 hours after each injection. Focused ultrasound and CRTNPs alone were able to significantly suppress tumor growth by greater than 50% compared to the control tumors. However, the combined CFUS therapy was much better than the individual treatments by themselves. This was also evidenced by a significant decrease in the tumor size and weights of the CFUS-treated tumors compared to the other groups, as you can see here. Flow cytometric analysis of treated tumors suggested higher expression of calreticulin in all the treatment groups compared to the controls. Immunofluorescence staining of the treated tumors suggested that CFUS-treated tumors had relatively higher CRT expression compared to the other groups, as seen by the red spots in those images. This increased expression of calreticulin led to an enhanced functional status of cytotoxic T lymphocytes that were positive for interferon gamma and granzyme B in CFUS-treated tumors compared to the controls. Interestingly, we also observed a higher fraction of antitumoral M1 macrophages that are good in the spleen of CFUS-treated mice compared to all the other groups, indicating the role of systemic immune response in these mice. This data motivated us to further evaluate the abscopal effect with CFUS therapy. Abscopal response is a phenomenon in which treatment of a local tumor causes regression of a distant tumor. After treating the primary tumors of these mice, we re-challenged them on the contralateral side and observed for their tumor growth. 80% of mice in both CRTNPs and CFUS groups resisted re-challenge up to 4 weeks post-primary tumor inoculation. To further understand the significance of adding focused ultrasound therapy to CRTNPs, we performed a vaccination study in which 4 million melanoma cells were treated in vitro with CRTNPs and focused ultrasound and then inoculated in mice, which were observed for their tumor growth for up to 30 days. CFUS cohorts had relatively delayed tumor take and progression compared to the CRTNP cohorts. This data also correlated with the data from ex vivo stimulation of spleen with TRP2 melanoma-specific antigen, which suggested a higher fraction of interferon gamma positive, CD4 and CD8 positive T cells in CFS cohorts compared to the CRT-NP cohorts. This data suggested that there was a superior melanoma-specific systemic immunity that got developed in CFS mice than compared to the CRT-NP mice. We also evaluated the levels of immune checkpoints in the treated tumors, as these proteins determine the efficacy of any therapy. Flow cytometric studies suggested higher expression of CD47 and PD-L1 in CFS-treated tumors compared to the controls. Though we were able to skew the balance towards an immunostimulatory dominant side with CFS therapy, immune checkpoints could have got upregulated as an adaptive resistance to our ICD-based approach. This data is really interesting, and it could be good because recent studies suggest that tumors with higher levels of immune checkpoints, along with higher immune cell infiltrates, respond better to checkpoint inhibitors. In conclusion, the modulation of CRT can activate both innate and adaptive immune responses. The addition of focused ultrasound to CRT-NPs can result in robust local and abscopal anti-tumoral responses against melanoma. Studies are underway in our lab to assess the efficacy of the combination of our therapeutic approach with checkpoint inhibitors to maximize therapeutic benefits and survival. Thank you. I thank my advisor, Dr. Ashish Ranjan, and all the lab members, and thank you for your attention in listening to my presentation. I would like to take any questions.
Thank you so much. Questions? You have questions? So I have a couple. I missed the pressure, the ultrasound pressure that you're using.
I think it is 6 megapascal.
6 megapascals. Yeah. And can you say anything about the, I noticed that you're using your nanoparticle intratumorally.
Yes.
Have you thought about, is it systemically toxic, and is it something that could be used?
That's a very good question. Actually, we tested even intravenous injection of nanoparticles, but and the tumor growth pattern was similar to the intratumoral injection. But we were really interested in treating local tumors to see if we can generate systemic response just with the local therapy. That's why we kind of analyzed the tumors more for the immune profile in the intratumorally treated tumors, and we did not investigate the intravenously injected tumors further.
Okay, but you think it's tolerable?
Yes.
Okay. Other questions? All right, well, thank you so much.
Thank you.